Dear colleagues, I want to share with you interesting clinical cases. Patient first time was in my clinic in 2019 after some 10 couple weeks before. During my examination, percussion negative, palpation negative, no pockets, no sinus tract, nothing. Also, I see no radiolucent area in X-ray, and we decided about two possibilities, about follow-up or about CBCT, because we know that sometimes we can see apical lesion in CBCT scan that we can't find on the regular X-ray. This patient back in 2022, a month after the pain and using of antibiotics. During examination, this time again, nothing on clinical examination, percussion negative, palpation negative, no pockets, no sinus tract, but now we can see some radiolucent area in apical part of the tooth, and my diagnosis now, it's previously treated tooth with asymptomatic apical periodontitis, because now it's not pain, and I recommend retreatment. Patients say yes and disappeared. And I see him again in 2024, this year. And again, it's a couple of weeks after pain in the same area. But now on examination, again, nothing, no percussion, no palpation, no pocket, no sinus tract. It's strange. On an X-ray, I'm not sure that I'm seeing here some radiolucent area. If you will compare 2022, this area that's clearly radiolucent, and now I'm not sure, maybe we have something big, but maybe no, and I convinced patient to go to CBCT, because on CBCT scan we can see it much better. We know it very well. And please, again, additional example, we see the huge hypodense area that totally destroys the border with the sinus. We have also apical lesion. We have also odontogenic sinusitis, and again we have a final diagnosis of asymptomatic apical periodontitis, although odontogenic sinusitis question. And what's interesting for me, if I have CBCT scan, to understand the anatomy, because when we're looking for periapical X-ray, we see just two canal. Why just two canal? And we know about artifacts around metal, around prefabricated metal post here, but we understand when we see the axial slice and cornal part and axial slice in apical part, that we're speaking about very rare anatomical configuration in upper molar C-shaped canal, and we understand that all clinic procedure will be not so easy. A patient convinced me to work through the crown. He wanted to change the crown after the treatment. It's okay. I start to work. You see the prefabricated post in the middle of the pulp chamber. After removal of the ultrasonic, I used my own approach. I combined night eye rotary with high velocity without solvent, and after use regular velocity, regular rotational speed night eye instrument with solvent. And also I continue to use the instrument for final scrubbing. My idea more than 10 years ago was to use SF file to scrub remnants of gutta-percha on the wall. It's worked well together with solvent. And as you see in the end of procedure, I did a working length determination also with their headstrom, but also in this case, after the cleaning of the canal, we see the exudate, the pus exudate, and we understand the pus exudate is a sign of very active infection. It's million of polymorphonuclear that death after oxidative burst. That's understandable for me in this specific case. Surely I will use calcium hydroxide, and mostly not because of antibacterial properties or not because of dissolution properties, but because it's the only material that can really dissolve LPS, lipopolysaccharide, the most powerful antigen of gram-negative bacteria. And this is so important. This symptomatic cases. This case was asymptomatic clinically, but it was symptomatic when I'm speaking about signs of infection. And after 1 month, I have a totally clean canal. Again, huge irrigation with sodium chloride. All of us remember from Olsen Zweig, the Hasselgren, that on the second time NaCl will be much better work after the calcium hydroxide. We have some synergistic effect between them. And because it's C-shaped and it's very difficult anatomy, we understand that just cold lateral compaction, it's not enough in this case. And I use combined technique, and in this combined technique, I much more emphasize the work with warm vertical compaction. This is final result. You can see, and I finish with temporary double seal, and I will invite this patient 6 months later. And in this specific case, I think I will use CBCT for follow-up, because just CBCT will give me the result of situation and the sinus and the final understanding what we can have in this specific case. Thank you. I hope it was interesting for you.